Okay, the topic for tonight is COVID-19 vaccine is safe and save lives. And this is sort of a timely topic because the vaccine, I think, was rolled out now three and a half weeks ago. And obviously there's a lot of questions about it. There's a lot of uncertainty about it. There's a lot of unknowns about it. And there's, excitement and yet fear about this. So I think this is just going to be an excellent talk. So I'm going to introduce our panel. First, we have Dr. Sanober Kable. She is a pulmonologist, lung specialist here in DFW. Just has been an extremely amazing resource for AMWPA in all things lung diseases with flu season and COVID-19. Our next panelist is Dr. Nilofer Syed. She's a rheumatologist at UT Southwestern, who, as you know, specializes in autoimmune diseases, so she can offer a perspective on patients who are immunosuppression and have different chronic medical conditions. We have Dr. Shazia Khan. She's an internal medicine hospitalist at THR, and I think she can help offer the perspective of the hospitalized patients that she has come across at the hospital and seeing sort of the spectrum of COVID-19 presentations. We have Dr. Javed Akram, who is an infectious disease specialist here as well. And he is at THR Presbyterian Denton, and he'll certainly be our expert in terms of all things COVID-19 and can certainly give us a great overview of his thoughts on COVID-19. We have Dr. Faryal Ghaffar, who is a pediatrician and pediatric infectious disease specialist at Dallas Pediatrics and Infectious Disease Associates. And while this vaccine is certainly not available yet to the pediatric population under 16, I think Dr. Ghaffar can certainly speak to COVID-19 in children and what age in the pediatric population they can get the vaccine. And lastly, Dr. Horath Kamili, who is a board certified allergy immunologist, a rheumatologist, and internal medicine physician. She works at Allergy Partners of Dallas Fort Worth and everyone's been in practice for a number of years. And so certainly Dr. Kamili, with her allergy immunology background, will certainly answer a lot of questions about the vaccine. I think there's a lot of questions about side effects and immunity and whatnot. So I'm going to go ahead and have Dr. Kable start with her presentation.
Thank you, Tasneem. Hi, everybody. I am going to quickly go over these slides. If you have any questions, if I go too fast, let me know. We want to leave enough room for discussion at the end. So thank you for American Muslim Women Physician Association for taking the lead on getting the preventive talks to the community and getting these discussions out and get all the questions answered. So I think I wanted to start with this slide for you guys to know how important right now it is that we get vaccinated. If you look here, now this data is from November of 2020, and COVID-19 is a third leading cause of death here. This data is from Johns Hopkins and CDC, and there were 230,586 deaths at that point. As of today, we have 371,862 deaths in the United States just from COVID-19 alone. So it's a deadly disease. Now, this is another good graph that I found that kind of gives you cumulative incidence of COVID-19 infection after people got vaccinated with Pfizer vaccine. So this is the vaccinated individuals over time, and this is the placebo. These people did not get vaccinated, and you can see over time the infection just kept rising. Same thing here from Moderna. These are the people that did get vaccinated. These are the people that did not get vaccinated. So just in a nutshell, science in the face of fear proves that science does work in patients that do get vaccination. Now, just to kind of give you a brief overview, what are the coronaviruses? So the coronaviruses is a large group of viruses that cause diseases in humans as well as in animals. There are different kind of strains among coronaviruses. So before COVID-19, there were coronaviruses as well. They would cause infections, however, not as severe as COVID-19. So COVID-19, the other name for that is SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome Coronavirus 2. Another, I think, the question that I get a lot is, what is the difference between flu and COVID-19? So they're both viruses. They're two different kind of viruses. They're both contagious. And there are two different vaccines for each one of them. Also very important, and that's why we emphasize getting flu shots earlier this year, and it was on the AMWPA platform that I did a presentation, that both infections can coexist at the same time and can actually potentially increase the severity of the illness as well. So we recommend vaccination against flu, and now that we have COVID-19 vaccine, we're going to talk about that. And both of these can lead to severe respiratory illness. This is a slide just I wanted to go over just for you to realize why, you know, we still keep saying, even if you get vaccinated, that you still have to take precautions, because once you get a vaccine, or even when you get the infection, all of these systems have to get activated. So once somebody gets the vaccine or the infection, we have macrophages. They're going to basically digest the germs and make them into what we call antigens. That antigen, your body's gonna recognize, the B lymphocytes are gonna recognize them, and then start making antibodies in our body. And those antibodies will eventually kill those germs, as well as we make what we call T lymphocytes. These are memory cells. So if in the future we get an infection, the T lymphocytes, they get activated and they know how to fight this infection, and they start our memory and start getting the cells that are infected with the virus, start basically killing them. So this process doesn't happen in a day. Once a person gets infected, it'll take about 2 weeks for us to develop an immune response to fight that infection. And same is true for COVID-19 vaccines. And that's why until the second dose is given, the effectiveness of the vaccine is, number one, after the first dose, not as good as after the second dose. And number two, it will take 2 weeks after the second dose for us to get to that 94, 95% immunity that each of the Moderna or the Pfizer are basically in the trials showing us that effectiveness is there. Now for the COVID-19 vaccines, there are different kinds. However, we'll just focus on this top one. This is called mRNA vaccine. It contains some material from the COVID-19 virus that gives instructions to our cells to make a harmless protein. We call that spike protein. Basically, oops, sorry about that. I think okay, so basically, if you look at this slide, this injection has the genetic code or RNA of the virus, and it is coated with lipids. So when it's inserted into the injection site, which is usually we are, I mean, when I vaccinated, we use the left arm. However, it could be the left or the right arm. It's in the deltoid muscle. We give this injection to. That vaccine enters the cells and it makes the spike protein. That's how our body recognizes that there is a foreign material in our body, and it makes these antibodies. And then once these antibodies are made, and if the person encounters this virus either from the community, then this will trigger our body to fight against that infection or the infected cells. So this whole process takes about 2 weeks, and that's why it's very important to keep all the precautions going. Currently, we have 2 approved vaccines that got the emergency use authorization. We call that EUA. This is a side-by-side comparison of Moderna and the Pfizer vaccine. So the dosing is a little bit different. We have Moderna is at 100 microgram dose, while the Pfizer is 30 microgram dose, so a little smaller dosing here. For Moderna, the booster dose or the second dose is on day 28. for Pfizer, the booster or the second dose is on day 21. Now, it could be plus minus 4 days. So you could take it 4 days earlier or 4 days later. Moderna is only approved for 18 plus. However, Pfizer is approved for 16 plus. Moderna, after the first dose, it's 80% effective in preventing an infection. However, the Pfizer is at 52%, but after the second dose, Moderna goes up to 94.1% effectiveness, and then Pfizer goes to 95% effectiveness. In either case, until you get the second dose and you give it about 2 weeks, you still have to keep the masks and everything on even after that period as well. And we'll talk about why. Now for Moderna, there has not been any significant allergic reactions except for patients with shellfish allergy. And for Pfizer, there were some reactions, anaphylactic and severe allergic reactions in the initial rollout. However, you just have to be cautious if you have severe allergies. And I think the allergist and the infectious disease specialist will talk more about that if there are any questions. Now, as far as the pregnancy is concerned, there are no human studies, but the animal studies show no concerns for both the Moderna and the Pfizer. And the CDC guidelines do suggest it's a personal decision for people to make. However, pregnancy and lactation, it is recommended to consider getting vaccinated. Talking about the side effects, any one of you who had gotten the vaccine, most of the healthcare providers have gotten it. We really mainly got injection site pain. However, others are fatigue, dizziness, headaches, muscle aches, joint pains, and fever. And again, these reactions are not of concern because this means that your immune system is actually recognizing that there is a foreign material in your body and is trying to kick up an immune system. And if there is an immune response, if there's a robust immune response, you may have a little more reaction, but that's not of a concern or a worry. And now most people that we know after the second dose had some more side effects than after the first dose. But majority does really well. Now, the question comes is, should we stop doing precautions as soon as we got vaccinated? And that answer is a no. You still need precautions after vaccination. As I said before, it takes about 2 weeks after the second dose to develop full immunity. With the vaccines at best being 95% effective. Now, so there is still a chance that even if you get fully vaccinated, that you could still get infected. And given the infectivity rate is so high, we still recommend that everybody should wear the masks, keep your distance and continue hand washing even after getting vaccinated. Now, question again is, okay, I'm ready to get vaccinated, but who at this point is in the priority list to get vaccinated? As we know, at this point, we have just a certain number of vaccines that are being distributed. So because of the limited supply, there was a group 1A, which is direct care, including hospitals, long-term care, EMS, home health, outpatient, ER, urgent care, pharmacies, last responders and school nurses were the 1A. That was the first group that got the vaccination. And then we also had long-term care residents, and the facilities also were in part of 1A. Now we're at 1B, in Texas at least, where if you're 65 plus, or if you're 16 plus, and you have at least one chronic medical condition, including pregnancy, that you can get vaccinated. Not every place that's vaccinating is considering 1B at this point. However, a lot of the places are, and they are getting more and more 1Bs in. As far as where to get vaccinated, I think the best place to call is calling your local county health department. So if you live in Collin County, you'll call the Collin County Health Department. If you live in Tarrant County, you will call the Tarrant County Health Department. Whichever county you live in, you call your county health department, and they can guide you, and as well as can put you on a wait list. There will be some large vaccination hubs coming to Texas pretty soon. And also you can go to this website here, and it will take you to the website right here as it's showing. And it can also give you the vaccine availability map. It can tell you where the hubs might be. So a lot of this you can access on this website, just for your information. Okay, and just for cost of vaccine, it's free of cost. If they're private practices, might charge $14.85 admin fee. However, I think with the vaccination rollouts and the hubs, it should be free of cost. Now, this one is called V-Safe. So after you get vaccinated, you can report your side effects, common side effects to CDC. You can go onto the website, CDC website, and get yourself enrolled in V-Safe. Just Google V-Safe, and you can also find it as well. And then you can report any side effects. And again, most of the side effects are injection site and very few fever, tiredness, chills, and headaches. And that ends my small talk. And this is all of us here. I think I have missed someone here, Dr. Camille, the allergist here, but otherwise I have everybody here on the panelist and the moderator. If you guys have any questions, please let me know. Thank you.
Thank you, Dr. Kable. That was excellent. I'm getting private messages on the chat on questions. So I am going to just start asking questions to the panelists. And I think before we start, tell me who has gotten all 2 vaccines. I have, alhamdulillah. Dr. Kable, you have, right? 1, okay. Dr. Akram?
Yes. I've gotten 2.
Hello.
Okay, Dr. Khan's gotten 2. Dr. Akram?
Both.
Both. And Dr. Syed?
Yes, I also got both.
And Dr. Ghaffar?
I just got one dose,
Oh,
the first
okay.
one, yeah.
Okay, so this is not in any order, but okay. Can taking Tylenol prior to vaccine affect the efficacy of the vaccine? Dr. Akram and Dr. Camille, what do you both think?
So there are 2 types of studies in this. It's for pediatric vaccines. I don't think, to my knowledge, there's anything for COVID-19 vaccine. But from our information from the studies for pediatric vaccination, some studies have actually shown that using Tylenol before vaccination or using an NSAID like Motrin or Advil before vaccination may blunt the response to vaccine. And on the other side, there are some studies that show there is no major effect. It doesn't seem to obviously augment the immune response. So in general, we recommend to avoid taking any medicines which lower your fever or pain even before you get the vaccine. So it is not recommended to take Tylenol or Motrin or Advil before taking the vaccine. Now, once you take the vaccine, everyone's reaction is different. Some people may complain of very minimal pain or soreness and may not even require any Tylenol or Advil. However, if after the vaccine there is significant discomfort, then that can be taken for supportive measures just to feel a little better, but it's best to avoid and wait to see what the reaction is like. It is not recommended to take it ahead of time just to prevent any symptoms. It may cause harm, it won't really help.
Yeah, that's true. That's what I got both vaccines on December 17 and January 6. So some of the physicians who got on December 16, so I had an experience talking to them, and most of those, obviously we don't get vaccine and go home, we have to go back to work. And so in that situation, I think the next day when they came back, they had sore arms. So that's when they started taking, some people prefer Advil, some they took Tylenol because they have a little feverish thing. But I don't think any of the physicians that I know, or they took anything before the vaccine. And I don't advise them to take before, because you want to wait and see that what kind of reaction you're going to get. If it's severe, you don't want to mask it. You may need care for that. So it's better not to take anything beforehand. I agree with the other physician, but like next day, if the pain is so severe, you can take it something.
Okay.
And but you have to keep in mind, make sure there's no kidney issues or any bleeding issues before you take Motrin or Aleve.
Yes. As a gastroenterologist here, the safest anti-inflammatory is Tylenol, acetaminophen. Okay, so the next question I have, these are great questions actually. If you had COVID and your test showed antibodies, when should you get the vaccine? Also, what are the chances of getting the virus again? Who'd like to take this one?
I can take.
Okay.
So this question has two parts. First is that if you had infection or disease, how long you have to wait, or do you have to take a vaccine? So most of the experts, and including CDC, I love Dr. Fauci and I listened to him. So I listened to him and he said that if you had a disease and you recovered, it's better to wait 90 days. That's the magic number, even on the CDC website, that wait for 90 days before you get the vaccine. But before that, the CDC say that if you have to have a vaccine and you have a disease, you had a disease, make sure your symptoms are completely resolved before you take the vaccine, because you don't want to mix and say that is it still the disease going on or it's the side effect from the vaccine. Right. So to be on the reason why they say wait 90 days, that most of the people who get disease, they have the antibodies to protect you for at least 90 days. So at least, I mean, to be on the safe side, you don't want to take the vaccine, and also you can give a chance for somebody else to take a vaccine during that time, and you can take it later on.
Yeah, they want you to complete
contraindication.
Yeah, so they want you to complete your quarantine for 2 weeks before you go and expose other people as well. So there are two reasons for it. Yeah, totally agree with you.
That's true. Yeah.
One thing I want to add too is that the antibody testing is not recommended before getting the vaccine. So even if you've had COVID, they're not recommending that you get testing for antibodies.
Well, can I please, this is Dr. Ayes. I have really a disagreement with that. The reason behind it is not because of we need to follow some a plan, biomarkers to see whether the vaccine is working or not. People that get infected, usually the antibody goes up to the level 100, 120, probably AU per ml, and go down. In our laboratory, see people even after 6 weeks will disappear. Now, people that get the vaccination, according to the data, they can go up to 300 AU per ml, according to them. And they say probably 90% of that, or like 80% or something, it could be whether after the couple of weeks of the second dose. So the question is, why we don't dose antibody to see where we at? Because there's people, they taking it right now as granted. You know, I got the vaccine, it means I'm immune and so forth, which is not true. In our laboratory, we have 70 employees got the vaccine after 3 weeks. None of them, barely, they have 3 or 4 AU per ml. Very few. Couple of people, they got infected 3 months before or 2 months before, they got level at 44. So I have a little disagreement with the CDC they're saying, because we need to see at what level we can reach some sort of security, quote unquote. Remember, those half-life of those 83 days, it means informant, they may be gone. Now, the thing is, I'm sorry?
No, I mean, I think you bring up a very valid point. But I think as physicians, we, you know, for the general population, we can only give guidance based on the CDC recommendations. While I totally understand your point, I think just in terms of the general population, we're going to go by the CDC guidelines. And honestly, the antibody testing, I'm not sure that we can necessarily say those are probably the most valid biomarkers in terms of sensitivity and specificity, but that is totally up to debate. But I really appreciate your comment.
Yeah. I think the other question was neutralizing antibodies. So
that's what I'm talking about, basically. It's not the regular, the binding, this is neutralizing. And then you talk about cellular immunity, CD4, CD5, how to monitor this. looking at upgrade interferon. All those are very important to go what, they can say about the guidelines, but
but the thing public. Is, for public, what we're discussing here is so for the vaccination, we have enough data, right? So I understand as a scientist, you'll always question that data, but I think this forum, our goal is to create more awareness instead of more causing more doubts in the mind. So as physicians, we can have this discussion, but as a general public, would I ask my patients with COPD to get vaccinated? Absolutely, yes. Do I think that antibodies should be followed or not? That's a totally separate question, I think, for a different forum, different talk, different times.
Agreed. Okay, thank you so much. No, I actually really appreciate the comments, but I think, like Dr. Kable said, I think that's a discussion among us physicians. Going on to the next question, I've gotten several questions regarding this. People with weak immune systems, how effective are vaccines in people with poor immune systems? I think perhaps what they're getting at is patients with autoimmune conditions, patients who are on immunosuppressive therapies. Dr. Syed and Dr. Kamili, do you guys want to take this?
Sure, I can talk about the immunosuppressant population, and I'll let Dr. Syed go talk about the autoimmune. So as far as being immunosuppressed and having low immunity, it could be if in patients who are on medicines for various reasons, like steroids or other immunosuppressive medications, and they may have a lower immune system. The issue with vaccinating that population is we may not see a good response as we want to see. However, as far as the safety is concerned, it is a safe vaccine. The ones that are available right now, the Moderna and the Pfizer vaccine, they're both mRNA vaccines, so they don't contain any live vaccine. In patients who are immunosuppressed, whether, as I mentioned, they're on some medications or they have some other underlying conditions like diabetes or immunosuppression, like immunodeficiency disorders, we are hesitant to give live vaccines, but that's not the case for COVID-19. This vaccine that we have, the ones we have available right now, are the mRNA vaccines. So they work and they're safe. They may not respond, may not have a good and a robust response, but that would not, make me say not to give the vaccine because it may still have some effectiveness. And then I'll let Dr. Syed talk about patients who have autoimmune disease because their case is sometimes a little bit more complex and they have some other concerns.
Thank you. Yeah, so the major issue with the patients with autoimmune disease as well is when they're on immunosuppressive therapy. So unfortunately with the vaccine trials, they did exclude patients on immunosuppressive therapy. And as you had mentioned too, that patients, sometimes, especially if we extrapolate the data from influenza and pneumococcal vaccine, there are certain medications that can certainly diminish the efficacy of the vaccine. So ideally, it is recommended to get vaccinated prior to starting immunosuppression. But even in patients, if they're on immunosuppression, it's also, there's certain medications that ideal timing can also make a difference in terms of the effectiveness of the vaccine. There are certain medications that are more notable like methotrexate or rituximab, which are used to treat autoimmune diseases. And so it's just something that patients, if they're on these type of medications, it's recommended that they talk with their doctor just to get clarification on timing. But otherwise, in general, we are recommending all of our immunosuppressive, all of our autoimmune patients, who are on immunosuppressive therapy to get vaccinated when they can.
Perfect. And I'd like to just comment on that because I specialize in Crohn's and colitis. So the majority of my patients are on steroids or anti-TNF agents, anti-integrin blockers. They're on a whole gamut of immunosuppressive agents. And I think each specialty feels a bit differently about vaccines and immunosuppressive therapies. But in our GI community, we heavily recommend all of our patients to get vaccinated against COVID. And, we say perhaps, if you're going to get an infusion, maybe time your vaccine about a week apart from your infusion or your injection or whatever biologic agent that you're on. But I think the efficacy of these vaccines in general in patients who are immunosuppressed is questionable. However, I think the benefits far outweigh any risks or any questions. Okay. Is the 90-day, okay, no, actually, let's see. This is a common question. How can you trust a vaccine that was rushed and rolled out in 9 months, while normally it takes years to develop a vaccine, especially many doctors and virologists in Europe go against it, and for a virus for which survival rate is quite high indeed. Dr. Akram or Dr. Kable, would you guys like to address that?
Yeah, I mean, that's, I was, I think, listening some experts and they have the same question, but if you see that some of the politicians, they wanted to this vaccine before the election. So why it took longer to bring this vaccine after the election? Because there is a authority in America called FDA. So their director, they said that at least I want to wait 2 months to see what's going to happen with this vaccine before I approve it. So it was not rushed. It was done proper way, but obviously this was the need of the time. So they, the first thing is that they found this new technology, mRNA vaccine, which is way faster and compared to the other regular vaccines. And secondly, that all the steps were taken, all the trials were done properly, and the FDA took proper care, and they waited for a reasonable time before they gave approval. And so I don't think it was rushed, but it was done appropriately for the need of the time.
I'd like to. Yeah, I just wanted to say one thing. I think a lot of the research is delayed and sometimes takes years, not because it can't be done sooner. It's because of the funding, number one. There was a lot of money that was poured into it. So most of these pharmaceutical companies, they have to put some amount of funds aside to do the research. And they don't have a lot of money every year, especially vaccination is not a money-making business for these companies. And US poured a lot of money into it to make it happen as fast as we could. And all that scut work, all that paperwork where we have usually delays, it was made where we actually got it moved faster from those things which will take years or months in another world where COVID didn't exist. So I think there are many, many factors that actually, the safety wasn't compromised is one thing, because we have enough data for as far as the safety is concerned.
Yeah.
I think what the general public just wants to know, and I hope you guys can confirm this, because this is my understanding as a non-pulmonologist, non-immunologist, is, as you said, no steps were skipped. I mean, I'm involved in clinical trials, and I mean, it's a well-oiled machine. They look at every single patient, every little side effect. My understanding is nothing was skipped, no safety, as you mentioned, was compromised, and nothing was rushed with the actual trial, correct? Is that a fair statement for the general public to sort of alleviate their concerns?
Yeah.
Right.
And I would like to add one thing here, which would kind of address the concern that you brought up, that the mRNA technology has been studied for a while. So that was already there. And as Dr. Kable pointed out, it was something that was not a priority to make a vaccine for that. There was not the need. And right now we have like 3,000, 4,000 people dying every day. So there's a difference in, the priorities of all the research sciences throughout the world. So the technology was already there. That is not new. So we were lucky that we had that infrastructure and that science was already done. And the other thing about mRNA technology is once the genome was out, getting that mRNA for that spike protein, it didn't take them long. They had it back in March when they had all the information. So then after that, producing a vaccine, it was a matter of weeks. And of course, as we mentioned, the trial was not cut short. The trial was done as per all the requirements, and it met all the rigorous criteria that we need to look at. And one more thing that's very important, I think that the general public needs to understand, that whenever we do a trial for any medication, we talk about this long-term side effects or long-term data, and we have these registries and we keep the surveillance for a while. And that is true for most medications to see if there is any long-term side effects. For vaccines, for the most part, the majority of side effects of vaccines occur within the first few weeks. So if we see any sort of reactions, allergies, any sort of adverse reaction, it'll happen within a short period of time. And so we have that much data. The first vaccine was given, I think, back in June. So that long term is already available. Now, obviously, we feel more comfortable if we have years and decades worth of data, but we also have to look at what we're dealing with here. But we don't expect, based on our studies that we have for flu vaccine, pneumonia vaccine, and all other vaccines, if we do see a reaction, we see it within a few weeks, because the vaccine, as Dr. Kable mentioned in her talk, it gives the antigen to the body produces an antibody response, and that is where, if there was something to go wrong, that's where the body would have a reaction. And so having a reaction 6 months down the road after the vaccine is extremely unusual. So I think we have good enough long-term data enough. It's always nice to have more, but I think we don't have to worry about long-term data so much.
Great. I'm getting several questions about children. So when can we expect the pediatric population to be vaccinated? When should we expect children to get the vaccine? Dr. Ghaffar, do you want to address this?
So we still need data in children. So it's still, they're working on it. So it seems like it will take still few months. It could be 2 months, it could be 3 months before we have the data that, it will be licensed for children. Right now, as you know, the Pfizer vaccine is for 16 and over. So at least we'll have some of the adolescent will be covered. And we have seen with different diseases that adolescent are at more higher risk. Like even for my asthma patients, adolescent, whenever they have an asthma attack, they are prone to more complications, because of their compliance and stuff. So at least we have, for Pfizer, we have the 16 years and older, so we can start vaccinating the ones who are at higher risk, like asthma patients or cancer patients. But of course, we are still waiting on it to be licensed to the one less than 16 years. And for Moderna, it's still not licensed. It's only for adults 18 and over. So it will still, we have to wait on that. It will, I'm expect, from whatever the data I'm looking at and I'm hearing from CDC and different web meetings and stuff, it may take another few months. It could be 2 months, it could be 3 months, we have to wait.
No, I think they're recruiting for the trial. I believe
Yes.
Plano has a site too, where 12 to 17, they're recruiting right now. For
Yeah. Okay, which vaccine has less side effects, Pfizer or Moderna? Dr. Kable, do you want to take this? I think you went over this in your slides really quick.
I mean, really, Moderna does have less side effects, especially as far as the allergies are concerned. I can have Dr. Kamili talk about that, but we have had some anaphylaxis with Pfizer with the initial rollout. Haven't had that with Moderna, and most of the side effects do happen after the second dose, but I don't think that's a concern where you choose Moderna over Pfizer or Pfizer over Moderna. I don't think that should play a role in that at this point, unless they have severe anaphylaxis history.
Yeah,
yes, I don't think we have enough data for Moderna yet, because it was launched about 10 or 12, 14 days after Pfizer was introduced. For Pfizer, they just actually published their anaphylaxis data, I think on Tuesday or Wednesday. And only 21 out of the almost 2 million cases, 2 million doses that were administered, there were cases of anaphylaxis. We don't have the data for Moderna. I know in the news there's information about one patient. So there may be one, there may be more.
I thought that was shellfish allergy, but wasn't anaphylaxis.
But the patient had an underlying shellfish allergy.
Right.
So it's hard to tell. Again, as physicians, we don't only rely on the news data. You want someone to actually look at it to say this was an allergy or not, because a lot of the reactions that are you may hear from your friends on social media, and they say I had a reaction and everything is called allergy, but that's not the case. And so we want to differentiate into what it actually is as an adverse or a side effect, which is like sore throat or fever or sore arm or fever, whether it is just an enhanced immune response or it's an allergic or an anaphylactic response.
But
so
can I just to address the question to the general public is
yes.
Just
so far, I said, I don't think we have enough data to say whether one is better than the other.
Great. Dr. Khan, can you tell us about what COVID is like on the inpatient service in the hospital? I've seen it firsthand. I feel like there's a huge COVID surge going on right now in the hospital. Can you tell us about your experiences on the front line?
Absolutely. So right now in my hospital, we've got about, I would say, out of the 350-bed hospital that I work at, I would say about a third of them have COVID, and the numbers are climbing. Unfortunately, because of the gatherings that we had over Thanksgiving and Christmas, we are seeing a lot of those patients coming in now. We're seeing actually multiple family members coming in. We're actually seeing younger patients coming in as well in their 30s and 40s. And I mean, the situation is pretty dire in the hospitals. We've actually had to make room. We've got patients camped out in the emergency room right now for a couple of days. We've actually had to open up a separate hallway to transfer patients there, and the ICU is packed beyond capacity. Unfortunately, we have reached the place where we really, the intensivists and pulmonologists have to decide who is more in need of a ventilator. So unfortunately, the very thing that we were talking about, you know, in the middle of last year, it's coming to pass. So
I feel like it's worse than the summer.
I definitely believe so.
Yeah.
Definitely believe so. You know, thankfully, we're not seeing as much influenza as we are seeing COVID. But the situation is pretty dire right now in all of the hospitals. I talked to my colleagues at Medical City Plano and at my particular hospital, Presbyterian Hospital Plano, and I mean, it's bad. What we're trying to do is, you know, once the patient comes in, they're hypoxic, we get them started on remdesivir, and steroids already started. We follow their inflammatory markers. And, you know, if it seems like they've got a superimposed bacterial pneumonia, we get them started on antibiotics for that as well. We're not using as much tocilizumab as we were in the summer periods, but for certain patients, you know, we take that out as well. But really the hallmarks that we're really trying to do, we're trying to prevent early intubation. Mm-hmm. We're really trying to work with remdesivir and plasma, as well as steroids in my hospital. And, you know, thankfully, a lot of patients do respond to that. But, you know, unfortunately, mortality is still pretty high. It remains so in the hospital.
Yeah. Thank you. No, it's really scary times, and they're projecting, you know, according to the UT Southwestern data, 30 to 40% surge in the next week or so. So, okay. There's a question here for Dr. Akram. Is this vaccine also effective for the new strain of virus? We keep hearing about this new strain abroad, and there are some pockets of this new strain here. What are your thoughts?
Well, I think as the time goes, we're going to find out this new strain everywhere. Right now, it's in Texas also, and it's not only in Europe, it's here. So most of the experts, what they're saying is that, number one, that there's not much information about that new variant yet. And if it is a change in the spike protein, hopefully these new vaccines, both Moderna and Pfizer, will cover. But if there are enough studies and cases where the pharmaceutical companies, they're saying that if they find that this new variant is not covered by the current vaccine, they have a very easy way to change or do some changes in the vaccine to cover that strain also. But as for I know, and whatever I heard and read, that there is no data to say that this strain is not covered, or there's not enough cases to say that it's not covered.
And the good thing is they're saying that from the data that it's not more virulent, it's more easy to spread around. So at least that's good, you know, because it needs a lot of mutations to become more virulent. So which is, you know, and normally every day when you have virus in your body, you know, you get a virus, every day it mutates, but it has to mutate a lot, multiple times to become more virulent. So at least that's a good news.
Dr. Camille, question, how long do we think the immunity lasts with the vaccine? Do we know?
So I think so far we do know from the early studies, again, we don't have studies beyond 6 months. So far we know that there is data to show, there was some studies for the Moderna vaccine, actually, that there may be some sort of decrease in the immunity after 90 days, but we don't know what happens after 6 months. So for now, I think we do have information to see that it does last up to 6 months. And hopefully we'll have more information coming in from the trials once we have more follow-up data from the ones who have been vaccinated for over 6 months to see what the long-term data and what the 9 and 12 month looks like.
Thank you. Dr. Syed, once vaccinated, would you still need all the precautions while going out in public, or can we feel comfortable going out without a mask?
Yes, so it is still going to be very important for people to continue wearing masks, social distancing, because the question with the vaccine is we still don't know if it reduces transmission. So even if patients, they could still potentially get infected and still transmit the virus to other people. So that's still being looked at. So even after the vaccine, all the same guidelines are still in place for social distancing, contact precautions, all that.
In the second point, I think one of the presenters say that it's 94-95% effective even after the second dose. So and also people who have immune issues, they're immune suppressed or age also, their immunity may not be as strong as even 91-92%. So there is a still chance that you can get infection or disease after even the second dose. So all the precautions are necessary till we reach to that point where majority of the people are vaccinated.
Okay. We have so many questions. So Dr. Ghaffar, what if a person takes their second dose past the 21 days for Pfizer or past the 28 days for Moderna? Will it affect it to efficacy if you're late on that second dose?
Okay, so of course, the recommendation is to take in a timely fashion. There is a grace period of like 4 days. They say that if you are, 4 days late, but the problem is we don't have any data. This is too early to know. For other vaccination, I can tell you, like if my patient missed one vaccine and he was even 6 months late, I tell them that you don't need to repeat from the beginning. You don't need to take the first dose. You can just take the second dose. So probably that's how it may be for the COVID vaccine, but we don't know. So because this is an emergency situation, that's a pandemic, we want to take the vaccine in a timely fashion. So it's not like, if I have a patient who took pneumococcal vaccine and he didn't come on time, okay, you can take it a little later. But here we don't have enough data and we want people to go and take the vaccine at the recommended timing. Although there is a grace period of 4 days, because that nobody can exactly go on that day. Like if it's 21 days, you can miss 21, so you can go by the 25th day. But we don't have much data to say what happens if you go after you miss for more than 4 days. That recommended.
I think as most of the people, they are watching the news in UK, they said that you can wait 12 weeks.
Yeah.
But, our CDC and FDA and all, Dr. Fauci, they said no. In America, we have to go what the pharmaceutical companies have studied.
Yes.
So that's what we have to follow.
Yes.
Okay, question, have the doctors gotten the vaccine? I think, yes, we've all, alhamdulillah, received the vaccine. Question, I think this is a question for Doctors Akram and Camellia and Ghaffar and Kable. Well, actually everybody. Why is it that COVID-19 affects different people differently? Some are simply without any sickness, and some have to be intubated. Who wants to tackle that?
Yeah, I usually tell my patients and my staff, the nurses, they always ask me the question. So I said, if you are strong, healthy, you're going to have more side effects. You're going to react more aggressively. And so I think like in the presentation, it was said that it's an immune response, how your body reacts to that antigen and how aggressively it makes. And other than that, it depends that how, if you're allergic to a lot of foods, then I think the allergist can talk about that. But that's what I think is that, like in the study, they say that if your immune system is weak, your immunity maybe 90%, 91%. That is probably goes for the side effects too. That if your immune system is weak, so your response to the immunity and this side effects will be less. That's how I understood that.
I'm sorry, I think the question was, why is it that the actual virus affects people differently?
I think it's with any disease, if you take flu, or it's a multifactorial kind of a response in your body, it's the human body, how it reacts. So even with flu, if you take a patient with flu, I have patients with flu, they'll be running around, and I have a patient with flu who will be in the hospital on oxygen. So it's very difficult to say that it's only related to COVID. It's with any diseases I have seen that different human beings, they react differently. It depends on your inflammation, your immune system, other genetic factors. It's very difficult to pinpoint one thing.
Well, I think with COVID, however, we have seen so much mortality, such a short time. It is not a disease that I think we have seen for decades.
Yes.
This is definitely something different. And there's been a lot of hypotheses on the immune response, like the infectious disease expert is saying. Everyone is different on how they're going to respond to the infection. The way I explain to the patients, and since this is for the general public, if you see a snake in your house, what would you do? You would kill it, right? Or throw it out. That's the normal response. People that have this abnormal response to the COVID-19 virus, for example, when their body sees that snake, it's burning the whole house down. It's not stopping. There's no stopping to the immune system. So they go into that cytokine storm syndrome. And that's why we see most of that on day 10 to 14, where we see the hypoxemia set in, the lung getting all these infiltrates. And so that's an immune response. It's a cytokine storm that's setting in. And what's triggering it is really a mystery. And we'll probably find out in about a year or 2 years. But yes, I agree that this is an immune response and much different than what we have seen with flu. I mean, flu killed people over years. This has killed people in 3 months, as many people that are died.
And it's very surprising. Like I see a pediatric population, and I have kids. They have COVID, and they respond very good. They just have runny nose. Why? Nobody knows. So it will take some time for us to learn.
And one thing I want to mention too is that, because of the underlying conditions that patients have, since that affects them in terms of their risk of severity of COVID, even patients who are just obese, or they just have like diabetes or high blood pressure, they might feel otherwise healthy, but that can definitely put them at risk for COVID. So I think that's also very important to keep in mind, that just having obesity could be, put patients at more risk to have
Absolutely. I think obesity has been considered one of the single most risk factor for poor outcomes. And I think, again, the obesity itself generates so many inflammatory markers in these patients too. So so much underlying inflammation with obesity as well, with diabetes and stuff. So I think those are the higher risk factors to begin with for pulmonary respiratory failure.
Dr. Camille, any thoughts?
I agree with what Dr. Kable said. I think it does depend on the body's immune response and what your body wants to do with it. And then I think we have another risk factor, 2 other risk factors other than obesity, and for which these are not modifiable, are age. Elderly people tend to do worse, and males tend to do worse than females. So it's really that. And again, those will be some of the genetic factors that are coming into play, certain receptors which are higher in males and females. And then the body's reserve, how good is their lung reserve? How healthy have they been before that they can actually deal with such a strong immune response? And that's what, eventually some people end up in the hospital and some don't. But I think it's really important for the public to understand that we don't know who that person is. So there could be, and I'm sure Dr. Khan and Dr. Kable will have seen in their hospitals, you will have a young, healthy, with no other known risk factors that we can tell, maybe in the hospital struggling to breathe, and an elderly, frail female may do okay. So I don't think we should, look and take our chances and play that game. I don't think we have enough information. I think we know that this is dangerous and it's unpredictable at times.
With people who have had COVID in the past, are they getting more of a reaction to a vaccine because they have been exposed to it before and have memory?
I think so. We have enough data right now.
I don't think we have the data. I think
yeah, and we have not seen such case. We have not heard that the patients who already had COVID got more reaction compared to others. But I think we still need to wait and see.
But based on what we know, I think it's possible because the vaccine will cause an immune response. It's possible that they will have a stronger immune response because this is the second time that their body is exposed to that. So there may be a stronger immune response. But based, again, as Dr. Ghaffar mentioned, we don't know what that, we don't have enough data to really say based on good evidence-based studies, whether that's true or not. And again, I don't think that should keep you from not getting vaccinated, saying, oh, well, I did have it, so I won't get it because of the potential side effects, because we don't know if your infection gave you long-lasting immunity. So if you had the infection, it is still recommended that you get the vaccine.
Okay. When do you anticipate the majority of the population receiving the vaccine? When do you anticipate herd immunity achieving? Timeline, if anyone knows. Rough estimate.
Yeah, I mean, there are two elements in this one. One is the shipping of the vaccine to the places, and second is to vaccination. So if you see that, I think 10, 15 times more the vaccine has been shipped than it's been vaccinated. So there is a kind of like a difference in that. So we need a lot of manpower to vaccinate the population. So that is where mostly health departments, they were before overworked by testing people, and now those same people, they are vaccinating the people. So I think it's going to be a long way. I'll say that after summer, toward the end of summer.
Yeah, I think Dr. Fauci said early fall.
Yeah, that's
if everybody.
Yeah.
So roughly what percentage of the population, we can just talk about the US, do we need to have herd immunity? 70%, 60, what is there's a number, does anyone know?
Yeah, Dr. Fauci said 70 to 90%.
Okay. Is Dr. Khan, is a certain blood group type more prone to a COVID attack? Have you seen that in the hospital?
No, honestly, I mean, I have not, and I will actually defer this again more to our infectious disease and rheumatology experts, but I haven't noticed any particular correlation.
There is
I'm not aware of any either.
Yeah, there is a recent research that said that the people who are blood group O positive are more protective, and they won't get severe infection. And the one that have blood group A, they may get severe infection. But this is all like one data, so we don't know. There was only one study, so it's difficult to say.
Can people with food allergies take this vaccine? Who wants to take this one?
I'll take this one. So yes, people with food allergies can take this vaccine. There is no reason right now CDC is recommending to not take the vaccine. The only persons that shouldn't take the vaccines are the ones who have a known allergy to any of the ingredients in the vaccine. And this vaccine is not food-based. So there is no reason for someone who has any food allergies to not take this vaccine. If someone has a severe allergies to either foods or any other vaccines or injectable medications, we recommend to have maybe a 30-minute wait at the place where they get their vaccine. And obviously what the CDC is recommending for the vaccine distribution centers is to have availability for management of any allergic reactions. So proceed with caution, but go ahead and take the vaccine.
I'm going to answer this. My mother has type 2 diabetes, autoimmune disorder. Should she go for the vaccine or wait for some time? I think we can all agree, go for the vaccine.
Yes.
Sooner than later.
Yes. Okay.
Sorry, go ahead.
This is a general question about COVID. My whole family has COVID. We have mild symptoms. Do we need to wear a mask inside the house, or stay away from each other as much as we can a sick member still be able to reinfect a recovered one?
Like in the like in the vaccination trials, and also the recommendation is that even after the second dose, you still can transmit the infection, and you still 5% or 7%, depending on the age group, you still can get infection and disease. So yes, it's always, I think, better to wear the mask and take all the extra precautions till everybody's recovered.
Okay. This has been asked twice now. Let me find it. Is there a discussion about protecting the body through natural resources and promoting wellness through proper health regimen? That, and can someone speak towards CAM, complementary or alternative medical therapies, thoughts, data, anything?
The only thing I recommend to my patients, just like with any illness, like flu or any illness, I tell them they need to rest, take, a lot of fluids. But that's about it, which is like more like a general kind of information that we provide to patients.
I mean, I think the zinc and the vitamin C and vitamin D, Dr. Fauci, I think, is taking it too. So we all as a medical community are taking it as well.
Yes.
If that's what the question is being asked. Otherwise, besides that, we have no data to support anything.
Yeah, I think some places they are stressing too much on vitamin D, that helps, I don't know, to protect or to reduce the symptoms or something like that. That's what I heard a lot about vitamin D.
I think that started after Dr. Fauci commented that he was taking certain doses of vitamin D's, after which people started talking about vitamin D.
Yeah. D, C, zinc, all that.
Yep.
So the best preventive measure is still going to be wearing a mask.
Absolutely.
Well said.
I agree. And this is not data-based. This is just Dr. Ahmed based, but I'm a big believer of vitamin C. I take a gram every day. And my mother-in-law, my mom tell me to take the black galunji seeds as Muslims every day to help that. And I've been doing it, and I've so far, alhamdulillah, warded off COVID. Okay, can someone speak toward the COVID vaccine hubs that are to open in DFW? Does anyone have any information on that, or what website can they go to?
Well, I think the website I mentioned was CDC has some that link had from CDC. There's going to be one in Dallas, and I believe Collin County just has 10,000 doses coming up. It's not going to be a big hub. They already have the wait list exhausted almost.
Okay.
But for the Dallas, I believe they're talking about, at least from the CDC and everything, it seems like might be end of next week or in a couple of weeks. But again, nobody knows the timeline.
Okay. We're going to take a few more questions, but before I go on, just a reminder that this is recorded. You can go to YouTube and type in amwpa.org, and you can see all of our educational videos. And Dr. Kable's slides will be on there as well. If I have a lidocaine and xylocaine injection allergy, can I take the COVID vaccine?
Yeah, I think it goes back to the recommendation that only the ones who are allergic to any ingredient in the vaccine should not take the vaccine, and the vaccine does not have xylocaine or lidocaine.
If someone has a reaction to the flu vaccine, can they take the COVID vaccine? I think the answer is yes, correct?
Yes. Correct, same.
Yeah, I think the important thing that I found out also from CDC is that even if they had Guillain-Barré before, they can still take COVID-19.
Yes. And I think with the COVID vaccine, we're recommending our multiple sclerosis patients, our patients with neurologic disorders, correct, to get this vaccine?
Yes.
There was one question that I saw, and I come across this question all the time in my clinic, was if somebody has COVID infection, should they keep doing the testing, repeat testing till it's negative? So I get this phone calls a lot in my office about this. So the recommendation is that if you had COVID infection, you should just quarantine for 2 weeks until you are asymptomatic. That's when you are more infectious. And but you don't need to keep repeating the test because it has been shown that the test could be positive for 3 months. So I have sometimes these teachers school nurses who will call me and they said, oh, this child had COVID, and then we need to prove that the test is negative. So this comes across all the time.
Yeah, I think that confusion came when the CDC earlier recommended that 2 negative 24-hour apart tests before going to work or anywhere. But later on, they changed their recommendation to like 10 days to 14 days.
14.
Correct.
And asymptomatic, yeah.
Correct.
The last question is, if we don't have COVID, should we take vitamin D, C, zinc, and daily? Sure, why not?
Mm-hmm.
Yeah, that will help.
Okay, I think that is it for the questions. I am going to just open it up to the panelists. If anyone has any parting thoughts or wisdom to share before we end this. I'll start with Dr. Ghaffar. Anything that we didn't cover that you feel was important, or?
No, I think you covered almost everything that could I think of.
Dr. Kable.
Get the vaccine. It's available to you. Go get it.
Dr. Akram.
Yeah, I mean, that question comes even in the mosques, everywhere you go, that where I can get the vaccine. So I called a few of the local pharmacies and find out. So most of the pharmacies, they have their website and they have a little section where is COVID vaccine. So they tell you that which category they're giving right now and when it's going to be available to the public. So I think anyone who's interested in vaccine, they should be looking that website. And like one of the presenters said, that local health department. So every city has a different way of giving the vaccine. So I think we have to look all those channels to see that where we can get the vaccine.
Dr. Camille.
I can share a little personal anecdote because people were asking which vaccine should we get, Moderna or Pfizer, and I'm affiliated with 2 hospitals, and alhamdulillah, when I got the opportunity, I got this email from both places and I could choose. And honestly, I chose the one which was easier for me to get, which worked with my schedule. So don't waste time on which one works, just get the one that you can get.
Dr. Syed?
Yes, I agree with everybody else. So just get the vaccine when available.
And Dr. Khan, please stay safe. Thank you. Thank you everyone for everything you do. Dr. Khan, do you have any?
No, I would just recommend that one thing that we are doing in the hospital is that we are telling our patients that, and this has come up before, that if you receive the Pfizer vaccine, then, the next dose, it should be the Pfizer vaccine, yes. Rather than switching between the Pfizer and the Moderna. So in the hospital, at least, and even many physicians who are at multiple hospitals, they have to receive their second vaccine at their original hospital. So I think once it rolls out into the general public, we'll wait and see what the recommendations there are. And then the other question that came up was, what is the point in taking the vaccine, especially, if some people still remain unconvinced that it was rushed through in spite of the wonderful information that we received tonight. If you all could see what we see in the hospital, believe me, you would be rushing to get this vaccine. If not for yourself, then for your loved ones, for your spouse, for your parents. So that's all I wanted to add.
I agree. I think I was rounding this weekend, and I can tell you the most jarring thing is to see body bags being carried out of the ICU. It is just a vision, an image that I will never forget, because I don't think I've seen this much mortality on any service in my career. It's really just staggering. The naysayers, I think we should just have them walk through the ICU, obviously with a mask, and just see
right.
what we're seeing, because it would be sort of just a no-brainer, right? Like, oh my gosh, let's get the vaccine. But in any case, all right, Jazakallah, everybody. Thank you so much for the panelists and AMWPA for sponsoring this program.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
All right, thanks everybody.